Chapter 25 of your textbook covers immunizations and vaccines. In this chapter, we'll discuss types of immunity, active immunization, including the history of vaccines, the types of vaccines and examples, advantages and limitations of immunization, and factors influencing immunogenicity. We'll also discuss passive immunization, provide examples, and the benefits and limitations. And finally, we'll talk about adaptive immunity. So, what is immunity? We looked at this definition before, but it's the condition of being resistant to disease. Immunization is the process by which immunity is acquired. There are three types of immunization that we'll discuss further. Active immunization occurs with a specific antigen, and this can be by either natural exposure or administration of a vaccine. Passive immunity results from the transfer of antibodies from an immunized host to a non-immune individual. And adaptive immunity results from the transfer of cells of the immune system, usually those cells being lymphocytes, from an immunized host to a non-immune individual. Active immunization occurs when a person's own immune system is stimulated to mount an adaptive immune response to an antigen. As I mentioned before, it can be as a result of natural exposure or administration of a vaccine. Examples of natural exposure to infection include production of antibodies to specific group A streptococci after having a group A strep. Passive immunity can occur naturally. This transfer of antibodies from an immunized host to a non-immune individual occurs with the transfer of a mother's antibodies to the fetus or infant. As we've discussed in the antibody structure and function chapter, IgG gets transferred passively through the placenta, whereas IgA is transferred through breast milk. Passive immunotherapy is also an application in which pooled human antibodies are used to protect a person who has an immunodeficiency disease. The advantage of this type of immunization is that it provides immediate protection to an individual who has not developed immunity to a particular antigen. And finally, adaptive immunity results from the transfer of cells of the immune system from an immunized host to a non-immune individual. Adaptive immunotherapy involves the administration of these cells, such as lymphocytes, to treat patients with conditions such as immunodeficiency diseases or cancer. This type of therapy can be beneficial if the cells transferred are able to successfully establish themselves in the recipient. So an example of adaptive immunotherapy is the transplantation of hematopoietic cells into leukemia patients who have either undergone treatment with high doses of irradiation. So with active, passive, and adaptive immunity, there exists advantages and limitations. With active immunity, it induces long-term protection, but a limitation is that it takes time to develop. Passive immunity provides immediate protection, but a limitation is that it's temporary and memory isn't produced. And in some instances, it can induce hypersensitivity reactions. Adaptive immunity can transfer cell-mediated immunity, but with that, a patient's own immune cells need to be completely depleted, and there is the possibility of rejection of allogenic cells. Vaccinations are an antigen suspension derived from a pathogen that induce active immunity. Vaccinations are a form of immunoprophylaxis. So what that means is they are a form of prevention of disease through immunization. As all of you probably know, vaccines have had tremendous impact on public health by significantly reducing the incidence of illness and death from numerous diseases that have had devastating effects on civilization throughout history. In addition, there's also been experimental vaccines for cancer that have been developed as immunotherapy for patients who already have a disease. This is something we'll discuss in later chapters. One of the oldest and most feared diseases from ancient times was smallpox. This was a highly fatal and contagious disease that caused high fevers and pustular rash. Observations of patients infected with smallpox led to the procedure of variolation. In this procedure, fresh material was taken from the skin lesion of a person that was recovering from smallpox, and it was subcutaneously injected with a lancet into the person's arm or leg. The practice of variolation usually resulted in a less severe disease and also recovery, and it was performed for centuries in ancient China, India, and Africa. Even though the procedure was successful in a lot of patients, it wasn't without risk. A small percentage of recipients did eventually develop smallpox and died, and there were others who contracted other infectious diseases such as syphilis or tuberculosis from the injected material. In 1796, Edward Jenner used a cross-reactive material from cowpox lesions to vaccinate against smallpox. This early vaccine for smallpox was successful as the patients he administered to developed immunity, and the early vaccine itself led to the development of the modern smallpox vaccine, which is still derived from the virus that causes cowpox. Despite that early development of the smallpox vaccine, many years passed before scientists understood that microorganisms were the underlying cause of infectious diseases, and that the components of these pathogens could be used to produce protective vaccines. It wasn't until about 80 years later, in the 1880s, when the next vaccine was developed by Louis Pasteur against chicken cholera. Louis Pasteur later developed vaccines for anthrax and rabies, and all of the development of these vaccines were based on the principles of attenuation, that involves the use of bacterial viruses that have been weakened through exposure to modifying conditions such as chemical treatment, elevated or cold temperatures, or repeated in vitro passage in cell culture. The weakened microorganisms would not cause disease in healthy individuals, but are able to stimulate the immune response. In the 20th century, a tremendous expansion in development of vaccines occurred, and this was as a result of advances in scientific research techniques and laboratory technology. New methods of attenuating microorganisms by repeated culture passage and special media resulted in development of live attenuated vaccines against organisms such as Mycobacterium that cause tuberculosis and typhoid fever. Production of live attenuated vaccines for yellow fever and influenza A was also made possible in the 1930s. Development of toxoids, in which bacterial toxins are inactivated, were used to develop vaccines against diphtheria and tetanus. Attenuated viral vaccines include those developed for polio, measles, mumps, rubella, and varicella. An important development in the last part of the 20th century was the use of purified polysaccharides to treat bacterial infections. These vaccine preparations were developed that prevent diseases such as meningococcal meningitis, pneumococcal pneumonia, and Haemophilus influenza. These were as a result of production of glycoconjugates. The last part of the 20th century also saw the development of the first recombinant vaccine used against hepatitis B. The development of these various vaccinations has been referred to as the golden age of vaccine development, which occurred in the second half of the 20th century. The beginning of the 21st century has seen continued use and advancements in vaccine technologies. More live attenuated vaccines have been developed or improved on, such as those directed towards influenza, rotavirus, or herpes zoster virus. Advancements and improvements in the multivalent glycoconjugates have been developed, such as those for pneumococcus and meningococcus. A vaccine to help prevent cervical cancer was developed recently in the past few years that's based on production of genetically recombinant antigens from the human papillomavirus. We'll first talk about antigen preparations used in conventional vaccines. Conventional vaccines consist of different forms, either live attenuated microorganisms, inactivated microorganisms, or antigenic components of microorganisms, and these are called subunit vaccines. Attenuated and inactivated vaccines use the whole organism in their preparation, whereas subunit use part of an organism, so that may include toxoids from the organism, polysaccharides, or purified or recombinant proteins. As we've already mentioned, attenuated vaccines use live but weakened viruses or bacteria. So these organisms are grown under abnormal culture conditions, so they are no longer pathogenic but are still capable of stimulating an immune response. An example of an attenuated preparation of a vaccine is for tuberculosis. This was developed by Albert Calmette and Camille Guerin at the Pasteur Institute in 1927. The vaccine is referred to as BCG, Bacillus Calmette-Guerin, and it uses an attenuated strain of Mycobacterium bovis developed by growing the organism on culture media containing increased concentrations of bile. After several years, the bacteria had adapted to growing in media containing high bile content and were therefore suitable for use in the human body. Researchers have also developed a live attenuated bacterial vaccine against typhoid fever, and this consists of a mutated strain of Salmonella typhi packaged into capsules that are ingested orally. To produce this vaccine, the bacteria are chemically treated to induce genetic mutations that weaken them, so they're no longer pathogenic. Attenuated vaccines are actually more easily prepared against viral infections than bacterial infections. A major viral disease for which an attenuated vaccine was developed is polio. Polio is a serious disease that causes aseptic meningitis and leaves patients with disabling paralysis. In the early 1960s, Albert Sabin developed an oral polio vaccine from a live attenuated strain of poliovirus cultured in monkey kidney cells. The polio vaccine contains 3 serotypes of poliovirus that are capable of causing disease. Each serotype is a form of the virus that can be distinguished by the presence of specific antigens that can be identified by serological typing. Over time, a potent inactivated polio vaccine was developed, so the oral vaccine was no longer needed. And this one is also no longer available in the United States because it has potential adverse effects, although it is commonly used in underdeveloped areas because it's easier to administer than the attenuated virus. A live attenuated vaccine has also been developed to prevent influenza. The vaccine is administered intranasally. The main antigens that are targeted by the vaccine are 2 surface glycoproteins of the influenza virus called hemagglutinin and neuraminidase. These antigens are also used to classify the viruses on the basis of their serotype. We'll be discussing the inactivated influenza vaccine a little later, but a new attenuated influenza vaccine has to be prepared each year because of the high mutation rate of the virus. So this results in the synthesis of new antigens. The vaccine consists of quadrivalent suspension containing the most common circulating antigenic strains of influenza virus from the 4 common virus types. Additional live attenuated vaccines for viruses that I'm sure you're all familiar with include rubella for measles, rubella for German measles, mumps, and varicella for chickenpox, and a separate vaccine for shingles. The primary advantage of live attenuated vaccines is that they're able to replicate at a low level in the host and are capable of inducing both humoral and cell-mediated immune responses, which is especially important for viral infections because cytotoxic T cells are required in order to attack viruses during the intracellular phase of the viral life cycle. Because of the broad immunity induced by live attenuated vaccines, they generally induce an effective immune response after just a single dose. But despite these advantages, live attenuated vaccines also have significant limitations. It's very important not to administer vaccines containing live organisms to immunocompromised individuals, because although the organisms are attenuated, they may still cause severe disseminated and potentially fatal infections to patients with immunodeficiency diseases or patients receiving immunosuppressive treatments. Live vaccines may also not be recommended for use in pregnant women. On rare occasions, mutations may occur in the vaccine organism, causing it to lose attenuation and revert to the pathogenic form. Another limitation of live attenuated vaccines is the potential interference with replication of the organism in infants by maternal antibodies, necessitating a delay in the dosing schedule. And finally, careful handling and storage of attenuated vaccines is very important because exposure to heat and light may destroy the live organisms, causing the vaccines to be ineffective. This requirement poses a major problem in developing countries where refrigeration or appropriate storage is not readily available. The next type of vaccine is the inactivated one. So inactivated vaccines consist of intact killed viruses or bacteria. The microorganisms are killed by either heat or chemical treatment, so they're not pathogenic, but they still retain their antigenic properties. Examples of inactivated vaccines are the intramuscular vaccine for polio, the classic influenza vaccine, and the hepatitis A vaccine. A major advantage of inactivated vaccines is that they can safely be given to immunocompromised people because the organism has been killed and it cannot replicate in the host. However, this property makes it necessary to provide a larger amount of antigen in order to stimulate an effective immune response, and it may require 2 or more booster doses administered over time to produce protective immunity. Because inactivated organisms do not infect host cells, these vaccines predominantly induce a humoral immune response with little or no cell-mediated immunity. The last conventional vaccine is the subunit vaccine. These consist of 1 or more purified components of a pathogen that are capable of stimulating an immune response. The forms of subunit vaccines that are routinely used are toxoids, capsular polysaccharides, purified proteins, and recombinant protein antigens. Toxoid subunits are chemically inactivated bacterial toxins that are not pathogenic, but they retain their ability to stimulate the immune response. The pathology of some bacterial diseases, such as diphtheria and tetanus, is caused by a single exotoxin. Diphtheria is a contagious, life-threatening disease of the upper respiratory tract characterized by formation of a thick membrane that can cover the back of the pharynx, making it difficult to breathe. Tetanus is a serious bacterial infection that affects the nervous system, causing prolonged muscle contractions and sometimes difficulty breathing. The toxoid used in vaccines are added to induce the production of antibodies that can bind to exotoxins and neutralize their effects. Another virulence factor by some bacteria is the presence of a hydrophilic polysaccharide capsule that covers the outer membrane. The capsule allows bacteria to resist phagocytosis and other immune defenses by masking components of the membrane that might be targets of the immune response. If antibodies to the capsular polysaccharides are present, they can facilitate clearance of the bacteria by inducing opsonization or complement-mediated lysis. So, vaccines against encapsulated bacteria contain the purified capsular polysaccharides from specific bacterial strains that stimulate that production of antibodies. Examples of polysaccharide subunit vaccines are those directed towards Streptococcus pneumonia, Haemophilus influenza type B, and Neisseria meningitidis. A problem with the polysaccharide antigens is that they don't induce a good immune response, especially in infants and elderly, two populations that are at high risk for severe consequences of encapsulated bacterial infections. This is as a result of polysaccharides being T-independent antigens that stimulate IgM production with no immunoglobulins class switching or long-term memory response. So this problem is circumvented through vaccines composed of glycoconjugates, in which the polysaccharide antigens are linked to carrier protein, such as tetanus toxoid or diphtheria toxoid. These conjugates are then able to induce a more effective immune response by activating T helper cells, resulting in immunoglobulin class switching with production of polysaccharide specific IgG antibodies and generation of memory cells. Vaccines can also be composed of proteins from a pathogen. One type of vaccine that protects against pertussis, a respiratory disease also known as whooping cough, is composed of purified protein. Recombinant DNA technology made it possible to develop even more highly purified protein vaccines. These recombinant protein vaccines are produced by genetically modifying non-pathogenic bacteria, yeast, or other cells. Examples of recombinant protein vaccines include hepatitis B and human papillomavirus vaccines. The major advantage of subunit vaccines is the fact that they induce an immune response to pathogenic components specifically of a microorganism. They're safer because you avoid the administration of an intact organism into the host. Limitations include the fact that they require 2 or more booster doses to produce protective immunity, and they require an adjuvant to increase immunogenicity. Subunit vaccines also need to be multivalent or polyvalent, so they're designed to immunize against 2 or more strains of the same microorganism or against 2 or more microorganisms, so they produce a broad immune response. There are many factors that affect the quality of the immune response to a vaccine antigen. Important factors include age, individual's immune status, and the nature of the vaccine. And all of these factors are considered by immunization experts when deciding how a vaccine should be administered. Age is an important factor in determining how a vaccine should be provided to individuals in a population. Recommendations for age at which a vaccine should be routinely administered are based on age-specific risks for contracting the disease and developing complications, along with the age-related ability to respond to the vaccine. Typically, vaccines are given to the youngest individuals at risk for a disease, as long as it is safe and effective for that age group. The Center for Disease Control and Prevention has recommended schedules posted on their website. In the United States, for example, routine immunization against hepatitis B begins at birth because the hepatitis B virus may be transferred placentally. Vaccines for diphtheria, pertussis, tetanus, rotavirus, Haemophilus influenza, polio, and streptococcal pneumonia should begin at 2 months of age and require multiple inoculations. These are administered at specific time intervals through the first 18 months. The immune status of the individual also influences immunogenicity. The degree of the host immunocompetence, which also can be influenced by age, and the health of the host, affects how effective vaccines are. And of course, the composition of the vaccine itself affects the immunogenicity. Live attenuated vaccines tend to be the most immunogenic, whereas subunit vaccines tend to be the least. Vaccine antigens with a low level of immunogenicity require an adjuvant, a substance that enhances the immune response when administered together with a vaccine antigen. These help stimulate the innate immune system to induce the release of cytokines that activate adaptive immunity. Adjuvants can be classified as antigen delivery systems, which enhance the uptake of antigens by antigen-presenting cells, or they can be classified as immunopotentiators. These activate dendritic cells to present antigens to T cells in humoral or cell-mediated immune responses. In some vaccine formulations, the two types of adjuvants have been combined together. Despite the number of adjuvants that have been discovered, only a few have been licensed based on their safety and efficacy. The most widely used adjuvant and the only one licensed in the United States is alum, which consists of aluminum hydroxide and aluminum phosphate. Other commonly used adjuvants are oil and water emulsions composed of liquid dispersions of oil droplets stabilized with surfactants. The oil and water emulsions are mixed with vaccine antigens and are believed to stimulate the immune response by inducing release of chemokines and enhancing the uptake and migration of antigen-presenting cells. The ultimate purpose for using adjuvants in vaccines is to increase antibody titers and for some vaccines to induce cell-mediated immunity. Effective adjuvants can potentially reduce the dose of antigen needed in a vaccine. They can decrease the number of inoculations required and increase the speed and duration of the immune response. These are capable of enhancing immunity in both young and elderly hosts. Although conventional forms of vaccines have been very effective in preventing many infections over the years, we still do not have vaccines for many diseases that are major causes of illness and death around the world. These diseases are caused by viruses, bacteria, and parasites that have complex mechanisms of pathogenesis. The first step in producing an effective vaccine is discovering antigens from a pathogen that will elicit an effective immune response. This step can now be facilitated by the process of reverse vaccinology. In this process, computer analysis is used to screen an entire genome of a pathogen to identify genes that code for proteins that would make good vaccine targets. Once potential vaccine antigens are identified, it needs to be determined which antigens will induce the most protective immune response. For pathogens that show a high degree of variability, finding antibodies and antigens that can induce broadly neutralizing antibodies is most desirable. Aside from the vaccine design itself, additional research is being done to discover new adjuvants to enhance the effectiveness of vaccines, along with trying different routes of vaccine delivery to see which is most effective. Finally, in order to evaluate the effectiveness of a vaccine, more sophisticated methods are also needed to assess the immune response. Antibody titers have traditionally been used as indicators of vaccine-induced immunity, but by using techniques such as DNA microarray analysis, multiplex flow cytometry, and intracellular staining, the phenotype and activation status of individual cells of the immune system can be analyzed. Vaccines have been cited as one of the 20th century's greatest medical achievements. Because of routine immunization, smallpox has been eradicated worldwide, and polio has been eliminated from the Western world. Infectious diseases that were once leading causes of illness and death in the beginning of the 20th century, such as diphtheria and measles, have been greatly reduced today. An important feature of immunization is that it not only benefits individuals that receive the vaccination, but also reduces the risk of nearby persons who have not been vaccinated. When a sufficient proportion of individuals in a population have been immunized, unvaccinated individuals benefit and are offered some protection because there's little chance of the disease to spread in the community. The benefit of herd immunity or community immunity can be seen in this figure. In the top figure, no one in a population is immunized, so one or two individuals who are contagious spread the disease through the entire population. In the middle figure, you can see there are several immunized and healthy individuals. So some of the population gets immunized, so the contagious individuals spread the disease through the population, but less than in the figure above, in which no one is immunized. Then finally, in a population in the bottom figure, where most of the people have been immunized, the spread of the contagious disease is contained to very isolated individuals. Although there are various advantages and vaccines are very beneficial, they can also produce adverse effects in previously healthy individuals, but most of these are not severe. Local inflammatory responses can occur at the site of injection, and this is frequently reported because of stimulation of toll-like receptors by the vaccine antigen or adjuvant. Systemic inflammatory reactions are also common, such as fever, irritability, nausea, vomiting, and myalgia, and these usually occur 24 to 48 hours after injection of a killed vaccine or 14 to 21 hours after receipt of a live vaccine, but they should generally resolve within 72 hours. Other adverse effects include hypersensitivity reactions and effects related to the vaccine antigen or its administration. One major disadvantage is for persons who have altered immunocompetence, since they are at risk for certain immunizations and require special consideration. These individuals have decreased levels of humoral or cell-mediated immunity because of either inherited primary immunodeficiency disease or acquired deficiencies. The administration of live vaccines is contraindicated in immunodeficient people because they are highly susceptible to contracting infections. Therefore, they should be immunized with only inactivated or subunit vaccines. So now we've discussed the various vaccines and immunizations that confer active immunity. Next, we'll talk about passive immunity. So remember, we previously discussed that passive immunity results from the transfer of preformed antibodies to an unimmunized host. So antibodies can be transferred naturally to a mother's fetus or infant in two ways. The pregnant woman's IgG antibodies pass through the placenta to the unborn fetus, or maternal IgA antibodies are transferred in breast milk and ingested by the infant during nursing. Aside from this natural passive immunity, antibodies can also be passively transferred to a host as a means of immunoprophylaxis or immunotherapy. Human serum preparations are used to provide passive immunity to individuals who have been exposed to a pathogen but have not been vaccinated or developed immunity through natural infection. There are two types of preparations available. Standard human immune seroglobulin, or HISG. This is also known as gamma globulin and is made from pooled serum of thousands of donors. It contains antibodies to numerous antigens and is used as a prophylactic treatment for patients with deficiencies in antibody production. Specific human serum globulins is the second type of preparation to transfer passive immunity. This is made from pooled serum of donors with immunity to a particular antigen. Specific human serum globulin preparations contain a high concentration of antibody against the pathogen or its product and are used to treat individuals who have been potentially exposed to the pathogen but have not been immunized. The potency of the preparation is ensured by determining the antibody titer through laboratory testing. Specific human serum globulins have been developed for a variety of infectious diseases, including hepatitis A and B, varicella, rabies, tetanus, and respiratory syncytial virus. Another type of serum preparation is using animal globulins. These are usually prepared from horse serum. Examples of these include antitoxins for tetanus, diphtheria, and botulism, as well as antisera against snake venom. Antitoxins are antibodies that specifically bind to epitope on bacterial toxins. They protect against harmful effects of these toxins by neutralizing their activity. We already discussed monoclonal antibodies in Chapter 5, but they are derived from a single clone of B cells, and they have very specific specificity for a particular epitope of an antigen. This specificity is harnessed in the use of monoclonal antibodies as agents of passive immunization. Monoclonal antibodies are most commonly used for the treatment of cancer and autoimmune diseases, and numerous have been approved by the FDA for treatment of patients with various hematologic malignancies, tumors, and autoimmune disorders. The figure on the right shows an example of monoclonal antibodies used as therapeutic agents, and these can be made in mice. Humans may react to the foreign protein, so the antigen binding portion of the molecule can be grafted onto the constant region of human antibodies to reduce reactivity. It's also possible to humanize such antibodies so that only variable regions are incorporated into human antibody molecules. We previously discussed the main advantage of passive immunization is that it provides immediate immunity to the host, and this is because the antibodies are already present in the serum that's being transferred, so the host does not have to experience the lag period required for its own immune system to be activated by the antigen. The immediate protection can be especially beneficial in situations in which unimmunized individuals have been exposed to a harmful antigen. For example, in a person who receives a puncture wound containing potentially contaminated soil, but who has not been up to date with tetanus vaccination. Passive immunization can also be used as immunosuppressive therapy in select situations. For example, in an Rh-negative mother who's given birth to an Rh-positive fetus to prevent hemolytic disease of the newborn and future birth. Limitations of passive immunization include the fact that it provides short-lived immunity, with IgG having a half-life of about 23 days. In addition, passive immunity can induce type 1 or type 3 hypersensitivity reactions, especially to animal sera preparations. The last type of immunity we'll discuss in regards to vaccinations and immunization is adoptive immunity. In contrast to passive immunity that's aimed at providing the humoral component of the immune response, adoptive immunity or adoptive immunotherapy involves transferring the actual cells of the immune system to increase the cell-mediated immune response of the recipient. Human studies involving adoptive cell transfer have led to the development of exciting immunotherapies for cancer patients and transplant recipients. There have been advances in therapies that treat cancer patients with tumor-infiltrating lymphocytes that are activated in vitro, along with transplantation of hematopoietic stem cells into patients with immunodeficiency diseases. The use of tumor-infiltrating lymphocytes has been a therapy that's cited as the most effective treatment for patients with metastatic melanoma, and hematopoietic stem cell transplantation has been used with patients with multiple myeloma, non-Hodgkin lymphoma, or acute leukemias. Clinical trials are also underway in other exciting areas related to transplant immunology. In summary, in active immunization, a person's own immune system is stimulated to respond to an antigen. Examples of active immunization include immune responses induced by natural infection or treatment with vaccines that have been actively administered. Passive immunization involves the transfer of antibodies from an immunized host to a non-immune individual, such as the transfer of a mother's antibody to her fetus or infant. Treatment with commercial antibody preparations is another form of passive immunization. Active immunity takes time but induces long-term memory, whereas passive immunity is immediate but is short-lived. And finally, adoptive immunization involves the transfer of cells from an immunized host to a non-immune individual. And adoptive immunotherapy advances have been cited as effective treatment for patients with cancers and leukemias.